Okay, for those who have joined, we welcome you. We are going to wait for some few minutes so that we get others joining. Then we can start. Let's give it the next 19:05, 5 minutes. Hello again, everybody. My names are Maurice Tembo from SANOFI team. This is a KMA webinar. I was asked to moderate it. I think our moderator, due to unavoidable circumstances, could not make it. We are now over 100 people, and we want to welcome everybody in this webinar. We will have 2 sessions. Dr. Rilwan is going to take us on diabetes, management of diabetes, and basal insulin in the management of type 2 diabetes, case studies. And Dr. Rilwan Adan is the head of Lion Diabetes Care Center. And so we are going to learn real cases on basal insulin. And after Dr. Daktari's presentation, we will have one of my colleagues, John Telle, from Sanofi, and he will present on Lantas as a product. And then we will have a question and answer session for both Daktari and John. And then we hope to conclude by 8:30. So without much ado, I would love to welcome Dr. Rilwan to take the stage. Thank you, Dr. Welcome.
Thank you, Maurice. Thank you very much, Maurice. Thank you to KMA, I think, and Sanofi for organizing this. I think it's a key topic that we should be discussing, in the sense that I think we all know that the burden of diabetes is increasing, and these patients are being seen at every level now, and it's important for them to be managed well. And so I'll just jump right into the topic, which is basal insulin in the management of type 2 patients living with type 2 diabetes. And so we will talk about the indications when type 2 diabetes patients should be put on insulin, and for that matter, which insulin, and we'll discuss the preparations which are available, and when we should initiate them, as well as when we should intensify, pick up their management further, depending on the patients. So I'll just start with a case. I think I was told to discuss a few cases. And so I have a 52-year-old male patient with type 2 diabetes for 8 years. When we saw him...
Dr. Are you sharing your slides?
Yes, I am.
I can't see them. Can you share again?
Okay. Is it visible on your end? It tells me I'm screen sharing.
I can see it from my end.
You can see them from your end?
Yeah.
Yeah, okay.
John, can you see them?
Yes, they're okay.
Okay. I'm unable to see them from my end, but it's fine.
Oh, sorry about that. So when we saw the patient was on metformin combined with sitagliptin and gliclazide, maximum dose of gliclazide. We okay? Maurice, we're good?
We are okay now. I can see the slides.
Perfect. So the patient was on maximum dose of gliclazide, and this was since diagnosis for 8 years. And since diagnosis, actually the patient was on metformin, and it was stepped up with sitagliptin and then gliclazide for almost 5 years. The patient was on this combination and reported unintentional weight loss, frequency in passing urine, and other osmotic symptoms. Had neuropathic symptoms. The key thing here is the patient was quite adherent to the medication, and also lifestyle modification, in terms of this is a patient who watches what they eat, and they were keen on taking their medication and following instructions on what was being told on lifestyle modification. So HbA1c was at 12.1% at the time, and had hyperlipidemia. And I'll come back to the case, but first we discuss probably a little bit on the pathophysiology of type 2 diabetes. So when we talk about pathophysiology, I think initially we had this has quite evolved over time in terms of the pathways of the pathogenesis. We had the omnius octet, and now we're talking about the egregious 11. And so if you look at it from the diagrammatic part there, I think I work more with diagrams. I'm a bit photographic memory. And if you look at from the pancreatic level, we all know insulin is being produced. We all know what diabetes is to begin with. It's hyperglycemia, high blood sugar, and this is because of reduced insulin production as well as insulin resistance, both combined in the case of type 2 diabetes. And so when we talk about the pancreas, when we have the beta cell dysfunction, so we have the insulin not being produced as much as we would want to, and we have the incretin effect. When we talk about incretins, these are gut hormones which are produced in response to glucose. glucose in the blood. So when you have high blood glucose levels, you have high incretin hormones being produced. So that it can act on the pancreas to produce, act on the beta cells to produce insulin, and the alpha cells to reduce the production of glucagon. So when you lose this, you end up not having the pancreatic beta cells producing insulin, and you have the unopposed effect of the alpha cells producing the glucagon, and it's a counter-regulatory hormone which increases the blood sugar level. And so we talk about the pancreatic alpha cell dysfunction on its own. When we talk about adipose tissue, muscle tissue, liver dysfunction, this is the components of insulin resistance. This is what creates the insulin resistance, and hence insulin not working well, and you end up with high blood sugar. The brain dysfunction, we have a lot of talk about gut dysbiosis, immune system dysfunction, low amylin levels, and the kidney dysfunction. And we have at least now an armamentarium of medications which are managing type 2 diabetes, and both are trying to act at each and every pathway, so that you have multiple pathways being affected by medication, so that we can manage the type 2 diabetes. And so if you look there, if you see on the slide, I've highlighted pancreatic beta cell dysfunction, because this is where insulin really acts at. And the topic today is more about insulin. And this is the pathway in which the insulin acts to help manage type 2 diabetes. And so type 2 diabetes is a progressive disease. So if you look at the natural history of the type 2 diabetes, is that there is progressive dysfunction of the beta cells, and hence you have production of insulin being affected. So at the time of diagnosing a patient with type 2 diabetes, an estimated 50% of their beta cells have been lost. So by the time you're diagnosing your patient to have type 2 diabetes, so they're only functioning with 50% of their beta cells, because the other 50 is gone. So if you look at this, this is from the UKPDS. UKPDS is a landmark trial for type 2 diabetes. I think there are cohorts still being followed up, I think up to 40 years. It's almost 40 years now. And we have a lot of, from this study, we've learned a lot in managing type 2 diabetes patients. And if you look at this, you see that the beta cell loss continues over time. And by the time you have the diagnosis, you see that the loss of the beta cell still continues. And when this was extrapolated, you see that the loss has been happening way before the diagnosis of diabetes. And so that you can see the 0 there, that's when diabetes diagnosis was done. And upon extrapolation backwards to 10 years, the loss started happening 10 years back before diagnosis of type 2 diabetes. And that is the natural history of the disease. And so same here. As you see, both in the intensive treatment phase, conventional treatment arm of the trial, you see that there is also regardless of the treatment, you have the progressive increase in the HbA1c, because there is also the natural history of the condition is that the beta cell loss still continues. And so if you look at the various variables, when we look at type 2 diabetes, the blood glucose, the insulin that the patient is producing, and the beta cell function. If you look at the blood glucose, the one in blue there, as the blood glucose, you have hyperglycemia happening, and this is in a normal patient. So you see the insulin level just before diagnosis. This is more around the pre-diabetes phase. You have a hyperinsulinemic state. Usually patients have high insulin levels. But you see the reduction of insulin happening over time. And by the time there is diagnosis of type 2 diabetes, this patient has already started losing insulin, and that is the beta cells as well. The yellow mark there shows the loss of the beta cells. So when you lose the beta cells, you automatically lose the insulin. And when you lose insulin, your blood sugar keeps going up. And so that is the natural history of type 2 diabetes. So the focus always is on type 1 diabetes not having insulin. But from this graph, you see that type 2 diabetes patients also lose insulin because of the beta cell dysfunction that happens, and that had already started happening even 10 years before diagnosis of type 2 diabetes. So when you have loss of insulin and you have a hyperglycemic state, And this is even before diagnosis. You already have the insulin going down, the beta cell dysfunction is happening. Patient is in a hyperinsulinemic state because the pancreas is struggling to get rid of the sugar and is producing a lot of insulin. And so it reaches a point where now the pancreas starts losing momentum and it stops producing insulin commensurate to the sugar level. And so what happens is the blood sugar starts going up. And when the blood sugar starts going up, you have hyperglycemia. And when you have hyperglycemia, you have increase in free fatty acids. So what happens is the high glucose levels and the high lipids, or rather free fatty acids, you get causes glucotoxicity and lipotoxicity in the beta cells, and so causes apoptosis of these cells, destruction of beta cells. And when you have destruction of beta cells, you tend to reduce, obviously, the mass of the beta cell reduces, and you tend to have impaired beta cell function. And so when you have impaired beta cell function, you have high blood sugar levels, and so the cycle continues. And the oxidative stress causes the apoptosis of the beta cells as well. So you have all this coming to destroy this, and when this happens, you have the hyperglycemia being perpetuated further. And so what do we need to do? We need to break the cycle. And how do we break the cycle? Is by at least giving these patients insulin, because when you give this patient insulin, you reduce the burden on the pancreas of having to produce the insulin, and this insulin reduces the sugar levels, and so the glucotoxicity and lipotoxicity is reduced, and so the destruction of the beta cell is also reduced. So you tend to break that cycle by giving the insulin. And so when do we give these patients the insulin, these type 2 patients? So we give type 2 patients when they have hyperglycemia despite maximal oral glucose lowering agents. So this patient is on every class of the oral glucose lowering agents. They've declined insulin on multiple times, and you keep adding orals, and you're on the maximum dose, and the patient is still not being controlled. So you tend to give them the insulin. Though a lot of times we don't wait for that, but it tends to happen that some patients tend to decline. And so when you have a HbA1c of more than 10%, so when you do your HbA1c, sometimes at diagnosis, you note that the HbA1c is 11% or 12%. So do you start insulin in this patient? It depends. It depends on the fact that probably this is a patient who initially before diagnosis was on a high glucose load, or rather high carb meals, was taking a lot of sugar. On eliminating this sugar on a few orals and you put them on a proper meal plan, this is a patient who will probably control. But diabetes management is highly individualized. So when I say 10%, majority of the times, it's not all patients with 10% you initiate insulin. More than 10% you initiate insulin, but you look at the patient case by case. Acute complications, those who come with DKA and HHS, you tend to have significant hyperglycemia at presentation. You need to start them on insulin. In decompensated states like acute MI or an infection, or obviously hyperglycemia not with ketones. Sometimes you tend to have not the DKA itself, because they're not probably they don't fulfill the full criteria of the DKA, but they're having ketones in the urine, and they're probably having sugars of 18 or sugars of 12. 13, and you're noticing ketones, you need to put them on insulin. Uncontrolled weight loss, and this is the case that I presented. So you tend to see patients who come to you, they've significantly lost weight, they've not tried to lose the weight. This is purely unintentional, and these are patients who have insulinopenia, and they need to be initiated on insulin. Surgery, pregnancy, renal or hepatic disease, steroid-induced hyperglycemia, or diabetes induced by pancreatitis. Obviously, these patients don't have insulin because of the inflamed beta cells. And so insulin therapy is frequently required during the course of type 2 diabetes, and we do this so that we have proper glycemic control and so that we can prevent diabetes complications. If you let this patient stay with the high sugars continuously, they're going to start developing complications, which we need to avoid. And according to the UK PDS, patients who almost 80% of patients on oral agents require insulin supplementation when they've had type 2 diabetes for 9 years and beyond. So when you see patients who have had type 2 diabetes for 15 years and they're uncontrolled, and probably these patients needs to go on insulin. So this is not cast on stone, but a lot of times, depending on the patients, that is what happens. So back to our patients. Patient is on metformin, is on sitagliptin, gliclazide, unintentional weight loss. HbA1c is more than 10, as you can see there. So, and this patient is adherent to medication. This then again brings us back to the natural history of type 2 diabetes and what I just told you about the landmark trial UK-PDS saying that almost 80% after 9 years require insulin. So our patient needs insulin. So in this case, you need to stop sulfonylurea because these drugs both cause severe hypoglycemia. And you start them on a basal insulin and you uptitrate based on the patient's needs, and also tend to look at the patient's lifestyle and see the patient's meal plan and the patient's activity level and manage the patient holistically. And so when we talk about starting insulin on a patient, so what is insulin? Let's start, let me take you back a bit. And it's obviously a hormone secreted by beta cells in response to glucose and amino acids. And if you look at the graph down there, that is the normal response of insulin. And this is in every person. Especially if this is the normal physiological response. So for a person not living with diabetes. So you have the basal insulin, which is produced throughout the day in small bits that gets into the blood. And then in response to a meal, you have the glucose going up when you take a meal, or the sugar going up when you take a meal. So the body responds by producing insulin to get rid of that sugar out of the blood. So you have that spike at breakfast. And when you have lunch again, the sugar spikes and you have a spike in insulin to remove the sugar from the blood. And also at dinner, same response. So this is actually the normal physiological response of insulin to sugar or amino acids or any load that comes into the body. And so we have various insulins which are available that try to take care of the sugar levels based on the physiological response, and that you have the basal insulin there, which is produced throughout the day and in small quantities if you look at the graph. And then you have the prandial insulins, which are produced, which we give pre-meals, and this gives the spike just before you inject just before your meal, and after the meal, it tends to take care of the sugar of that particular meal. So you can see there at breakfast, at lunch, at dinner as well. And so we usually tend to give the basal one after dinner, bedtime usually. And so this is the usual treatment for type 1 diabetes. I know that's not my topic today. So we try to mimic the normal physiological response by giving a basal insulin and a prandial insulin, which the patient takes before every meal. And so these are mostly the basal, the prandial insulins you see here. This response is usually given by the insulin analogs. And you have the insulin, human insulin here, which is the regular insulin, short-acting insulin, which tries to mimic that. Although the analog has usually better profile as compared to the human insulin, but also serves the same purpose. And you have the NPH, which is more of an intermediate acting. And this is also human insulin and can act as a basal insulin. Sometimes we use it as a basal insulin. And so that is the types of insulin that we have. The basal there, which is the insulin glargine, and the aspart, lispro, and glulicin are the analog bolus insulin that we give, the rapid acting insulin. The regular insulin is the one we use for short acting human insulin, and the NPH is the intermediate acting human insulin. And so those are the options: basal insulin, which we can give once a day, usually at bedtime, or sometimes even twice a day. The premix insulin, you can give once, twice, or 3 times a day. The rapid acting we give at mealtime, and the combination of the basal bolus, which is the rapid acting together with the bolus. So what's the mechanism of action of insulin? A bit of biochemistry or physiology. It increases glucose uptake, particularly in the muscles, the liver, and the adipose tissue. And it suppresses glucose output from the liver as well. And obviously increases fat formation and inhibits the breakdown of fat. And so insulin has other benefits apart from just removing the insulin, the sugar from the body and creating a good environment for your cells. It also has anti-inflammatory properties, antioxidants. It's an antioxidant. There is some cardioprotection and neuroprotective. There's a few studies which have shown that, and antithrombotic and vasodilator. So these are quite important because this is more giving a cardiovascular renal benefit, because we know one of the major complications of type 2 diabetes is cardiovascular and renal disease, and which are the main drivers of mortality in our type 2 patients living with type 2 diabetes. And so if this confers benefit, it's an added advantage for the fact that these patients are actually quite protected when they use the insulin. And so over time, we know that there is no better reduction in HbA1c than insulin. I think now the GLP-1 are trying to tag along that line. But in terms of oral glucose lowering agents and compared to insulin, insulin is the best in reducing HbA1c. So patients with the highest HbA1c always require insulin to bring it down to at least the target level for that particular patient. So I'll come to a second case, which we have a female patient who is 59 years old, has had type 2 diabetes for 5 years and is hypertensive as well. She's obese. So patient came in with a lot of fatigue and headache, and has her eating habits. When we try to talk about her lifestyle, is that she has erratic eating habits because her sugars fluctuates a lot. It's always up and down. You have it going up, down, up, down. So when it goes down, she eats a glucose, or rather a high carb meal, so that she takes it up. When it's up, she's on human insulin, 28 units and 20 units. So when she takes that, the sugar dips down again, and she eats, and the sugar comes up, and she's on the insulin, so it goes down. So she's on premix human 28 and 20 units. That's almost 48 units daily, and atorvastatin. Her A1C was at 8.6. Her kidney is normal, and she had her urine albumin creatinine ratio was at 76. So you can see she had a bit of microalbuminuria there. And her TSH, because of the fatigue we did, was actually normal. And so I'll come back to the case, but when we talk about starting insulin for a patient, what should we consider? What should we look at? We should look at the patient's age. We should look at the schedule of the patient. We should look at their activity level, their eating pattern, their sociocultural factors, the complications that this patient already has. So for every patient that we see, we try to screen for complications at every visit, actually. The first visit, quite important, but for every visit, you need to try to determine if complications have set in. If these patients can self-manage themselves, because insulin involves a lot of self-management, patients have to monitor their sugars. Sometimes they have to titrate their insulin levels based on their sugars. So this is quite important. And also the life expectancy is quite important to look at. And which insulin should we consider? One, obviously, which can control overall glucose levels. That's why we are giving both fasting and also the post-meal glucose. One that is easy to use and start, that can be optimized or intensified quite easily, and manages to reduce the hypoglycemia. So the analog insulin, as compared to human insulin in a lot of studies, the analog insulin has better hypoglycemia profile as compared to the human insulins. Patient involvement in their diabetes management. Are these patients quite able to self-manage themselves is also quite important. So how do we initiate? So in type 2 diabetes patients, most of the time we face a lot of resistance when we try to initiate insulin. And so we try and remember, the patient has autonomy, so we can't force them to use the insulin that we want, however we want. So we try to talk to them, and the easiest insulin for them to usually accept upon starting is the basal insulin, because it's usually taken once a day. And so when we initiate the insulin, the basal insulin, we can use either you can choose to start at 10 units per day, or depending on the patient, you can have the patient's weight, and between 0.1 to 0.2 units per day per kg, you could start that at that level, and you adjust based on the sugar levels of the patient. And this you do, we usually teach the patients to try to self-titrate, and we set a target for them. You have to set a target, because when they inject this insulin, how low do you want the sugar to come to? So you need to tell them their targets for the fasting, for their postprandials, so that they know what they're working towards. And so this is from ADA. When you're trying to set glycemic targets, every patient has their own targets. We have majority of patients which fall into the regular target, but you have to look at the patient and decide how long has this patient had diabetes. You look at the disease duration there. So for a newly diagnosed patient, you might be quite strict on the target, as opposed to a patient who's had diabetes for the past 45 years, and look at the patient's life expectancy. If it's a very elderly 95-year-old patient who's had diabetes for some time, you can't start giving strict targets. So you try to relax the targets for them, both the postprandial, the fasting, as well as the HbA1c. These are targets you set for patients. And also, don't forget patient preference. Patients is always at the center. We have to use a patient-centric approach. Remember, this is a chronic condition which a patient has, and you need to work with the patient, and the patient preference is quite important. The resource and support system is quite important. So in our clinic, we have a diabetes nurse educator who is always a phone call away for these patients, for them to try to be guided on the titration. So the support system is also quite important when you're setting the target. So if you have support system readily available, you could try and set for them a more strict target. And so these are the targets which generally from ADA, if you look at it, HbA1c generally less than 7%. Before meal sugars, try to look at between 4 and 7.2, and 2 hours post-meal, that is postprandial sugars, we check about 1.5 hours to 2 hours post-meals, and we give them a target of 10 millimoles. This is general for majority of the patients who are not falling into the category of very elderly, or having severe comorbids, or not having had resources available to them. So when we initiate insulin, we start low and we scale slowly. So when you have the indications which we discussed present, you start with basal insulin once a day, preferably at 10 units. And then depending on the A1C, if you look at the patient and the patient is really glucotoxic, you can try to do at 0.2 to 0.3 units per kg. And you titrate every 2 to 3 days until you reach the target that you want. So we tell most of our patients, we need you to reach, if it's a young patient, probably newly diagnosed, it's 45 years, so you could have a target of probably between 4 and 7 or 6.5 millimoles of fasting blood sugar, because we usually titrate this, we give at bedtime or in the evening, and we titrate it with the fasting blood sugar. So you dose the insulin at bedtime, and you test the blood glucose in the morning, and you give them that target. So if they've not reached that target for about 3 to 4 days, now they can up titrate. So probably if they started at 10 and 3 to 4 days later, the fasting sugar is probably still at 12, 13, you can ask them to up titrate to 12 units and give it another 2 to 3 days. If they've not reached their target, they can go up to 14 units. So the moment they reach their target, they could stop at that. So the key thing here is with basal insulin, we try to fix the fasting. So because a lot of times the A1C is a component of both fasting, preprandial and postprandial sugar. So with the basal insulin, when you fix the fasting, you'll eventually end up fixing the A1C. And you note that the impact of the fasting blood glucose on HbA1c, if you have a patient with a HbA1c greater than 10.2%, majority of that sugar is up to 70% is being contributed by the impaired fasting glucose. So if you correct that fasting glucose, you'll tend to correct 70% of the hyperglycemia. So it's important for you to fix the fasting fast. And so this is what I was trying to explain to you in terms of titration. So once they reach their target, you stop. You don't have to add. If they're still above their target, you keep escalating the dose every 3 to 4 days as such. So any episode of hypoglycemia should be taken into account prior to titration. So if they've had an episode of hypoglycemia, be careful on escalating. Please do not escalate. Try to ascertain what caused the hypoglycemia and probe that before you escalate. And please talk about hypoglycemia symptoms with your patient. Don't assume they know. Give them all the symptoms of hypoglycemia so that they can be able to inform you. So if we come back to our case, our patient had real glucose variability, which sometimes can be caused by human mixed insulin. And so we stopped that. We initiated the patient on basal insulin combined with metformin, sitagliptin, and a nutritional meal plan was done. We also initiated the patient on an SGLT2 inhibitor in view of the fact that the patient was starting to have microalbuminuria, and also that contributed probably to the reduction in sugar levels, because the patient really improved, and the most important thing was the quality of life, because this patient was being almost debilitated by the hypoglycemia she kept experiencing because she could not continue with her daily life, and she because of the fatigue as well as the headaches that she had. So this really improved her quality of life. So this is another case. PN, she's 56 years old, type 2 diabetes, has had diabetes for 15 years and is obese, hypertension, and has dyslipidemia, presented with complaints of fatigue and uncontrolled sugar, especially the postprandials. The fasting seemed to be in range for her, and this patient was on Lantus of up to 38 units per day, and metformin and sitagliptin. And her A1C was still uncontrolled at 9.6%, because obviously if she's having postprandials of up to 18 millimoles, that would contribute to that. And she had chronic kidney disease. And so when we talk about intensifying insulin, or rather for this particular patient, this patient was on 38 units of insulin and was still remaining uncontrolled. And so when we talk about over-basalization, before I come to intensification, is when you have the greater than 2.7 millimoles difference between your bedtime and your next morning, that is the AM sugar level, it means that you're giving too much basal insulin to this patient. And if you go back and calculate with the patient's weight, you'll note that most of these patients have greater than 0.5 units per kg. And so we tend to get a lot of weight gain with these patients. And the increasing basal insulin doses, we get to target with fasting plasma glucose, but there is no improvement in the prandial glucose. And so the A1C targets are not met as well, because the prandial glucose is high, despite the fact we've met our fasting blood glucose level. So what happens in this case is we need to consider intensification, and we need to look at the basal insulin target dose that we're giving as well. So this is a patient who you've controlled the fasting plasma glucose using the basal, but the postprandials are still high. And so you need to intensify. And when we talk about intensification, we talk about a stepwise approach, in the sense that when we tend to consider now, because of the meals that this patient is taking, is why they're having high postprandial sugar levels. So what do? We need to consider a bolus for that particular meal. And so we tend to start with the biggest meal of the day. We ask the patient which is the biggest meal that they take, either breakfast, lunch, or dinner. And we tend to introduce a bolus at that particular meal, and we see the progress. And if we find that the prandial glucose target has not been met, we tend to escalate it to 2 meals and eventually to 3 meals if it has not been met. So what happens is if the target, remember we have to always give these patients the target so that we can optimize at least their management. And so we need to do multiple at least readings of sugar. So we can't intensify insulin if this patient is not monitoring their sugar level. So what happens is they need to monitor, they need to record for you, and you need to follow it up with them and at least guide them on which dose to introduce and which dose to escalate to if they're still not meeting target. So when we talk about the ideal basal insulin is one that mimics normal pancreatic basal insulin secretion. Remember when we discussed the physiology, the normal physiology is you have basal secretion of insulin throughout the day. So one that mimics that is quite good. And if you look at the human NPH, at least it goes up to 18 hours or so. If you look at the analog insulins, they go up to at least 24 hours basal secretion, and so you're covered for that. It's long lasting up to 24 hours, and it has it does not at least cause, there is reduced risk of nocturnal hypoglycemia with this once a day dosing of the basal insulin. And so the advantages of basal insulin is it requires one injection. It may help overcome the resistance of you initiating insulin with your patients, because when you tell them you just inject once a day and it's at bedtime and you go to sleep, they usually don't resist as much as the multiple injections which you want to introduce. So useful for patients with high overnight and fasting blood glucose. So a lot of patients who have hepatic insulin resistance tend to have high fasting plasma glucose levels. If you follow up your patients and they monitor their sugars, you note that there's some patients who tend to have high fasting plasma glucose levels. These are the patients with a lot of hepatic insulin resistance, and they require the basal insulin. So for patients who need help with injections, it's easy to use, and the titration is quite easy, like I've explained to you. A lot of our patients, usually when you explain to them the first time, the second visit that they come in, they usually self-titrate, both up titration and even down titration, because sometimes we tend to down titrate the insulin, and so they can do it for themselves. And so the analog ones tend to have less side effects of weight gain and hypoglycemia. But you note that a lot of our patients are not on insulin when they require them. And why is that? It's because of mostly, as I've highlighted there, physician inertia. A lot of times when I probe, it's because of the fear of probably hypoglycemia, even from the physician side. And I think the newer analogs probably have a better side effect profile when it comes to that. Reduced quality of life, reluctance to inject in public. And so this is for the patients. And perception that the disease is becoming more severe. So I think this is also coming from our end in the sense that we tend to use insulin to scare patients. Like if you don't control your diet, kama utakula vizuri, mimi taanza insulin. So that is quite wrong, because sometimes we tend to start insulin even at diagnosis. So let's not wait. Remember the indications that I've given you for initiation of insulin in type 2 diabetes patients. So we don't threaten our patients to make it look like now there is quote unquote end stage diabetes, that now they know that now now that the doctor has initiated insulin, I'm at the last stage of there's a patient who told me this, so this is the final stage of diabetes, and we don't have stages of diabetes as such, but that is the perception that is out there that we need to demystify for our patients. Fear of needles and pain from injection. I think the newer 4mm needles are quite friendly, and if you change them frequently, I think if you don't use pressure and it's sharp, you don't have that much pain. So patients do not feel empowered to take control of their diabetes. I think the most important thing for our patients, and not only those on insulin, is to teach them self-management, and at least to empower them. So diabetes self-management is very important, and we need to empower our patients to be able to do this. So perception that insulin therapy leads to complications or death. There are a lot of people who actually tell you that this can easily cause more complications for me, and that is not true. In fact, if anything, it will reduce the rate of the complications, because now your sugar is better controlled. And it's only, the other thing is that it's only for type 1 diabetes, because they don't have insulin. I think I was quite clear at the beginning with the pathophysiology and the natural history of type 2 diabetes, that these patients eventually develop beta cell failure and they require insulin. So when we come back to the case of our patient, the basal insulin, we continued, but we dropped the dose by about 20% initially, because we initiated a bolus with the biggest meal of the day. And the bolus is usually about 10% of the basal dose, the basal insulin that you are giving. Take 10% of it and initiate that with the meal with the biggest meal. We initiated empagliflozin because of the CKD that the patient had. This also contributed to some reduction on insulin. So hence we reduced the basal by a few percentage, and we maintained the other medication that the patient was on. Because she was obese, we put her on a low carb diet meal plan. We gave her a meal plan, and obviously advised her on adequate physical activity. So in summary, type 2 diabetes is a progressive, complex, multi-system condition. And it's due to its progressive nature, patient will eventually require insulin, and early restoration of normoglycemia may protect the patient from beta cell failure. So initiate insulin as soon as the patient requires, or as soon as possible, because you will tend to protect the patient from eventual beta cell failure, and they may not even end up requiring the basal bolus sometimes. So initiate the basal at 10 units once a day, and you can calculate depending on the patient's weight. Educate the patient and provide support. I think I can't overemphasize diabetes self-management. It is quite important. If you don't have a diabetes educator, please empower your nurse. Kenya Diabetes Study Group offers nurses education, and the nurses can provide this education on your behalf. And so with that, I come to the end of my presentation. I would want to share a QR code. This is a study we are doing at our center. It's for healthcare professionals. It's just a Google form. Just take a few minutes, please, and respond to that on how diabetes-related foot complications, foot ulcers are managed. So please take a few minutes. You could scan the QR code from the screen and just answer the few questions, just about 5 minutes. Thank you very much. And back to you, Maurice.
Thank you, Daktari. Thank you for that wonderful presentation that you've given us. It is very educative. I think the need for being patient-centric, initiation of insulin, titration, intensifying the insulin, and the beautiful cases we have seen will go to add a lot of value in the practice on management of diabetes. So as you scan the code and try to answer the questions, I know we have some questions in the question and answer session. Allow us to take that after the presentation from Sanofi. I have my colleague here, John Tele, to take us to the presentation of Lantas. Then we can come back to answer those questions. John?
Okay, thank you so much, Tembo. And thank you, Dr. Rilwan, for that very insightful presentation. So Tembo, just let me know when the screen is up.
Yes, it's up now.
Okay, thank you. So I'm John Tele, MSR with Sanofi, and today I'll be taking you through the role of basal insulin and specifically Lantas in the management of diabetes. So first of all, I'll just mention something that Dr. Rilwan has mentioned, especially when it comes to diabetes complication, which is brought up by hyperglycemia. As you can see, even by the time the diagnosis is done, macrovascular and microvascular complication might have already started setting in. So your choice of treatment is very important. So when it comes to the benefit of early insulin therapy in the management of diabetes, especially type 2 diabetes. So Dr. Rilwan has mentioned something about UKPDS, and again, I'll mention something about the UKPDS sub-study. As you can see, we have lifestyle. The patient was first put on lifestyle, then the oral hyperglycemic agents. This was both mono and dual, maybe metformin and SU. And lastly, the patient was put on oral hyperglycemic agents plus insulin. And as you can see, when insulin was added, the target HbA1c was met without any fluctuations. And if you can all agree with me, fluctuations lead to a lot of diabetes complications in our future. So what does it mean by a decrease of HbA1c by just 1%? This means 37% decrease in microvascular complication, e.g. kidney disease and blindness, 43% in amputation of fetal peripheral blood vessel disease. One of the things just to point out is for patients who have undergone amputation, remember how it will affect the quality of life. And again, for most of these patients, they die. I can say that they die younger. So for most of these patients, they will not live to their maximum of their full life or age. So the next one is 21% decrease in death related to diabetes, 14% decrease in heart attack, and 12% decrease in stroke. So we do have a hypothetical patient, again, by the name of Tony. Tony is 59 years of age, BMI of 28, HbA1c of 9.5%, is on maximum dose of sulfonylurea and metformin 1 gram. As already we've seen from Dr. Rilwan's presentation, Tony is a candidate of insulin. So I know we would all agree that Tony needs insulin, but let us just go through one of the slides and see why. So this is just a guideline on how to start insulin, and especially the basal insulin. As again, Dr. mentioned, if the patient's A1C is below 8%, we do recommend that you start with 0.1 to 0.2 units per kg per day. But if A1C is above 8%, the recommendation is 0.2 to 0.3 units per kg per day. As you can see, Tony is already falling in the 0.2, 0.3 units per kg per day. So let me just go. So some of the barriers that Dr. Rilwan has again said or mentioned. So we have the physician barriers, which are time to educate patients, resource to educate the patient, risk of hypoglycemia. Patients are reluctant to initiate insulin. So when it comes to Tony, what are the things that the patient will think about when it comes to insulin therapy? There's a concern about the demand of insulin therapy. There's restriction, e.g. harder to travel, eat out, feeling of personal failure, permanence of insulin injection, pain of injection, problematic hypoglycemia. So one of the things just to mention when you're thinking about the patient is, as Dr. said, you need to educate the patient on hypoglycemia. You need to tell the patient that when they're thinking about something like Lantus, it's a once a day injection, and the needles are so tiny that it's painful to withdraw blood than to inject the insulin. So what is the concept of basal insulin? First of all, I'll just take you back again to the physiological insulin secretion. So we have the continuous low level secretion of insulin between meals and throughout the night. As you can see, the dark black line, that is basal insulin, and that is where Lantus will work. And then we have the prandial insulin, which is the incremental stimulated insulin secretion following meals. So this slide has already been mentioned by Dr. But one of the things I just want to re-emphasize is when it's time to start insulin, the target is fasting blood glucose. So the relative contribution of basal hyperglycemia and postprandial hyperglycemia to the overall hyperglycemia by HbA1c. As you can see, this was with Riddle et al. And for Dr. Rilwan, it was with Mania et al., which showed the same results. So fasting blood glucose contributes, it's the highest contributor to hyperglycemia. As you can see, the higher the A1C, it can contribute up to 80% of hyperglycemia. So in type 2 diabetes, fix, fasting fast, that is a motto from Sanofi. So fix, fasting fast. This will lower the entire plasma glucose through the 24-hour period. As you can see, by just introducing Lantus, you will take down the matrix down to almost normal. So fix fasting fast. Fasting hyperglycemia has been shown to be the primary contributor to hyperglycemia at higher A1C levels in patients taking only oral anti-diabetic drugs. So Lantus, the ideal basal insulin. So when you're thinking about basal insulin, you think of Lantus. So why Lantus? So what are the characteristics of an ideal basal insulin? It should closely mimic the normal pancreatic basal insulin secretion. It should have no distinct peak effect, continued effect over 24 hours, once daily administration for patient compliance, and predictable absorption pattern. So all these are characteristics of Lantus, and these slides, we've already seen it. And as you can see with Lantus, it has no distinct peak. So you'll give your patient once a day, so that is a 24-hour dosage or D dosage. So Lantus is a true basal insulin. So let us look at the efficacy and safety profile of Lantus, because this is very important to us as clinicians, and especially due to most of our patients will be on other medication or will have other chronic conditions. So with Lantus, you'll have an average reduction of 1.6%. And this was witnessed after just 6 months. And we have studies to back up our allegations or our story. So we have the TULIP study, we have the INSIGHT study, we have the Durable study, we have the LAMET study, and we have the INITIATE study. And one of the things that I just want to point out, when it comes to between the TULIP and the INITIATE, the higher the A1C, you can see the higher the drop in when you're using Lantus or when you introduce the basal insulin. So when it comes to safety profile of Lantus, more than half of your patients who you'll put on Lantus for 6 months will experience no hypoglycemia symptoms. And according to DeVeris et al., 0.07% of the patients were the only ones who experienced severe hypoglycemia symptoms. For this, if you want us to go into details with the study, you can just contact me after the meeting and we'll share. So insulin glargine or Lantus did not alter the relative risk for cardiovascular disease and cardiovascular mortality when compared to standard of care, as shown in the graph below. That is by the Origin study. So I want us to compare Lantus versus premix. As we've seen, we had a patient via Dr. Rilwan by the name of Vigeti. The patient was already taking 48 units of mixed insulin in a day. So that was 20 and 28, 20 units in the morning and 28 units in the evening. So what are the limitations of twice daily split mixed regime? This increases the risk of postprandial hyper and hypoglycemia, as shown in the picture or the picture below. So, and one of the things that you would all agree, the insulin variability increases the effects of diabetes complications. So we should get a product that will prevent or will stop the insulin variability. And that is where introduction of Lantus would come in, because it would give a 24-hour coverage when it comes to the basal insulin. So this is just a comparison of once daily Lantus and human premixed, and that is according to the Juncker et al. So once daily Lantus reduces the rate of hypoglycemia and causes less weight gain versus twice daily premixed insulin. So according to Juncker et al., when it comes to HbA1c reduction, this was between Lantus once daily plus oral anti-diabetic agents in comparison with human premixed insulin twice daily. So Lantus had better reduction in A1C. Incidence of hypoglycemia was less or were less when the patient was on Lantus. Weight gain, the patient experienced less weight gain in comparison to the human premixed insulin. And finally, the insulin dose. With Lantus, your patient will use less insulin dose in comparison to human premixed insulin. So the Raskin et al. Again compared Lantus once daily plus OADs plus premixed insulin twice daily plus OADs. Again, HbA1c reduction, Lantus was better. Incidence of hypoglycemia, Lantus was better. Weight gain, most of our patients did not experience weight gain. Insulin dose was again less with Lantus. So Lantus and premix insulin both improve glycemic control. Lantus has a favorable safety profile compared to premix insulin. So switching from premix insulin to once daily Lantus with or without prandial insulin improves blood glucose control in type 2 diabetes. And one of the things to mention, even when you're switching your patients from premix insulin to Lantus, it does not mean that the patient will go directly into a Lantus and a rapid acting or a basal bolus. So some of the patient can go into Lantus plus oral antidiabetic drugs. And as you can see, again, we still have a reduction in A1C. Lantus plus prandial plus oral antidiabetic drugs. The patient can go into Lantus plus 2 prandial plus oral antidiabetic drugs, or Lantus plus prandial plus, or you can even add the oral antidiabetic drugs. So let us go back to our patient, Vigeti, who was on 48 units of Lantus, and you want to switch the patient from 48 units of mixed insulin, and you want to switch the patient into Lantus. So one of the things to know or to point out is when it comes to premix insulin, the 70% represents the basal or the intermediate acting. So you will pick the total daily insulin dose, and for Vigeti, it was 48 units per day. So you'll get 70% of 48 units, and that will represent the basal parts of the mix. From there, you will get 80% of the 48 units. Maybe Tembo will help me calculate that, and we'll see what our Lantus starting dose will be. So first you get 70% of the total insulin dose, then 80% of the long-acting parts will be Lantus starting dose. So with Lantus, and like all other insulin, we do recommend start low and scale up slow. So you can start with basal once a day. We do recommend that you can just start with 10 units, as Dr. Ilwana said. But one of the things to consider, if the A1C is below 8%, that would be 0.1 to 0.2 units per kg per day. If the A1C is above 8%, then you'd consider 0.2 to 0.3 units per kg when you're initiating. So Lantus should be injected same time every day. So if it is recommended that you do Lantus at bedtime, so it should be the same time every day. So as Dr. Ilwan said, self-management or titration is very important to empower the patients. With Sanofi and Lantus, we do have a simple way to go about when it comes to insulin titration, especially for Lantus. So if the patient has started on 10 international units per day, in the morning, the patient has not yet achieved their goal. So the patient, after every 3 days, they will up titrate with 2 units. So every 3 days, 2 units until they get to goal that you've already set with the patient. So Lantus is easy to use, and with the Lantus Solo Star Pen, you can up titrate up to 80 units. So how do we store Lantus? And remember, when it comes to storage, this will include both for Lantus vial, Lantus cartridge, and Lantus Solo Star. So Lantus should not be stored in the freezer and should not be allowed to freeze So if Lantus is frozen, discard Lantus, discard it. An opened Lantus vial, cartridge system, or the SoloStar device should be stored in a refrigerator between 2 degrees and -8 degrees. You can store it up to expiration. If it expires again, it needs to be discarded. But the opened or in-use SoloStar, this will include the SoloStar, the vial, and the cartridge, should not be refrigerated, but should be kept at room temperature below 30 degrees, away from direct heat and light. One of the things just to point out when it comes why we say it should not be refrigerated is injecting cold insulin will irritate the skin or it will be painful. So if the patient wants to refrigerate or the hospital wants to refrigerate the Lantus, then they should remove it 2 hours prior to injection so that the temperature can come back to the room temperature. So the opened or in-use SoloStar device, again, vial or the cartridge, must be discarded 28 days after being opened. So Lantus being an insulin, let us just look at the side effects and precautions of Lantus. So the side effects may include hypoglycemia, injection site reaction, and lipoatrophy. So when it comes to pregnancy and breastfeeding, a large amount of data on pregnant women, more than 1,000 pregnancy outcomes, indicate no specific adverse effects of insulin glargine or Lantus on pregnancy. And it is not unknown whether insulin glargine is excreted in human milk. So this is just a presentation or a summary of what I've mentioned. So these are your options with Lantus. You can have a basal oral regime or basal plus your oral antidiabetic drugs. You can have a basal plus rapid or bolus, basal bolus, that is +1. So Lantus plus a rapid acting, and in Sanofi you do have a rapid acting insulin by the name of Apidra. Or you can switch, as we've seen from the patient Vigeti, from Lantus or from a premix to Lantus. And you would go to either Lantus plus orals or Lantus plus bolus, or 1, or Lantus plus now the 3 boluses. So again, on the side, you can see that is a representation of Lantus vial. It comes as 1,000 units, and it's available in mission hospital and county hospitals under the access program. And the price is the same in the hospitals and the pharmacies around. So with Lantus, you choose what you know, over 18 years of real life experience in managing diabetes, proven efficacy, established cardiovascular safety, and sustained glycemic control. So these are just some of the sites when it comes to choosing the injection sites. We have the 3 possible injection sites. They include the abdomen, the thighs, and the upper arm. Thank you. And again, I'll just mention on Lantus availability. Lantus is available in a county hospital, mission hospital, and a pharmacy near you at the same amount, especially for Lantus vial that is available under access program. Thank you. Back to you, Tembo.
Thank you, John. Thank you, John, for that presentation on Lantus. I have seen a lot of people asking whether they can get the presentation. For the Daktari's presentation, that will be in the custody of KMA, and for John's presentation, we will you can get in touch with us as Sanofi. We will be able to assist you. We have had questions. I think to save time, we have around 20 minutes to go. So to save time, Daktari, you can go to the question and answer, and probably read and answer some of the questions and what is meant for For John, I think you can pass on to John, but I've seen most questions are for you, Daktari.
No problem. Thank you. Thank you. Thank you, Maurice. So I think the first question I can see from my end is, which class of hypertensive drugs would you recommend as initiation in a newly diagnosed diabetes and hypertension patient? So I think, like I said in my presentation, when we initially encounter the patient, it's good to risk stratify this patient in terms of trying to look out for complications and trying to screen for the complications that could be present in this patient, because with type 2 diabetes, the patient could present with complication at first diagnosis. So it's quite important to do that. And when you have a hypertensive patient who probably has creatinines are deranged and they're having CKD, or their microalbumins are deranged, these are the class of patients you'd probably want to start on ACE inhibitors or ARBs, angiotensin receptor blockers, so that at least it can help with the kidney condition, or rather the proteinuria or microalbuminuria as well. But I want to caution, please, let's not give these two drugs together, the classes, the ACE inhibitors and the angiotensin receptor blockers, because you can cause acute kidney injury. So because I've seen some patients coming from Mashinani on losartan and enalapril, that is wrong, because you can cause acute kidney damage. So you choose one, and you can initiate this patient on the two. Previously, all diabetes hypertensive patients we used to put on this class of drugs, but now guidelines are quite clear that the patients who have developed the complications are those who will benefit. Those who have not could probably benefit from the other classes. And then the other question is, where Lantus is not available, can we use NPH instead as basal insulin? Yes, I think I mentioned that in the presentation. We could, but I think probably John will tell you about the availability of Lantus. You could use the NPH as the basal. Are there instances when we can choose to start bolus insulin without basal insulin? Thanks. Yeah, so this could happen because I think with, for example, patients who have chronic kidney disease and probably the later stages of chronic kidney disease, these are patients who don't excrete insulin well. So these are patients you would not probably want to give a basal insulin, which would last in the blood for a long time. And you want to probably give small doses of insulin, because you see the bolus, especially the analog ones, get out of the blood by about 4 to 6 hours. That's the action time. So those are the patients. And then the other class of patients that I usually use basal only without bolus probably before the basal or without the basal is, for example, the pregnant patients. So diabetes in pregnancy is a wide topic, but the only oral medication we use for pregnancy is metformin. So if metformin doesn't control, we go straight to insulin. And so there are patients who usually have hyperemesis, and these are patients you don't want the insulin hanging around the blood for a long time, because they might end up with hypoglycemia. They're not feeding well and the sugars are high. So these are patients you probably want to follow with small doses of rapid acting insulin. So those are the few instances I could think of at the moment that you could start the bolus without the basal. So would you please kindly comment on how to start and titrate mixed insulin where basal insulin is not available? So you just probably would calculate the total daily dose that the patients would require based on the patient's weight. So it, on average, take about 0.5 units of insulin per day and multiply it by the weight. So that's the total daily dose of insulin that that patient would require. So from that, you give 2/3 of, you divide the total daily dose, 2/3 you give in the morning and 1/3 you give in the evening of the mixed insulin. I don't know if I'm clear, but if I was a bit fast, I can talk fast sometimes, is calculate the total daily dose of insulin that that patient requires, and that is based on the weight. And so we tend to take a figure of about 0.5 units. So multiply it by the weight, you get the total daily dose of insulin. So when you get that, you divide that into 2/3 for morning and 1/3 for evening. And so you can use the mixed in that sense. Amazing presentation. Doctor, is there any concern of nocturnal hypoglycemia when using basal insulin at night, especially in our elderly patients? So the elderly patients, again, remember, as the patients age, the creatinine, the kidney function also sort of deteriorates. And so how elderly is elderly? Diabetes is all about individualization of therapy. But as John has mentioned, when it comes to the analog insulins, it's much better profile for hypoglycemia compared to the human insulin, especially the mixed human insulin. So you really need to be careful with the mixed human insulin for this kind of patients. The basal insulin, you could probably start slow and probably titrate based on the patient needs. So you could look at it that way. Must insulin in type 2 diabetes patients be initiated only when HbA1c is above 10%? Oh, no. So I think I did. So 10% is a figure, actually for ADA, American Diabetes Association actually gives about 9.1% above that. But as I have told you, it's not a must. In diabetes, there is nothing cast on stone. Always individualize, individualize. So you probably have a patient who, for example, like the first patient I think I gave who was insulinopenic, who was losing weight. And this is a patient who is on therapy following everything. So this is a patient whose A1C was not even 10%, and we had to initiate insulin. So it depends on the patient. So not all over 10%. And then again, you have a newly diagnosed who is at 11%, who was probably taking a high sugar load. When you remove that high sugar load, probably this patient may not require insulin. So it's sort of an individualized kind of basis. It's not cast on stone, but majorly look at the patient's lifestyle, look at the patient's condition, look at the patient's, for example, this patient has ketones and the A1C is at 8.5%. This is a patient who requires insulin because they're insulinopenic. So there are certain factors that you need to look at, but go back to, again, the slides on indication. That actually gives you the majority of the patients who you would want to initiate insulin on. Okay. Thank you for comprehensive, precise talk. Okay. What's your take on medications such as statin, HCTZ, beta blockers that are associated with increase in glycated HB in patients with DM? Yeah, so those kind of the beta blockers, so counter-regulatory hormones of the epinephrine or epinephrine, those are HCTZ is associated with metabolic disturbance. So statins. So these are drugs we usually use, patients require, and we need to co-manage the patients with comorbidities, because sometimes you have a patient who is having angina or arrhythmias and may require these beta blockers. You need to give them. So I think it's always about risk versus benefit analysis, and you look at it. HCTZ probably you could substitute with another antihypertensive, because again, HCTZ tends to have a bit of hyperuricemia, which again, these patients have. So you need to sort of balance and see if the patient can do without it, yes, but there are some instances which the patient can't do without. For example, a statin, because it reduces the risk of other comorbidities like strokes and heart attacks. So if this patient has already had an episode of an MI or an episode of a stroke, this is a patient who has to be on a statin. So that's the risk versus benefit of the patient that you need to look at and probably individualize the therapy for this particular patient. So how available is our health system? So that, John, I think you will answer with the availability of the Lantus in Kenyan health system. Provide recording, all that's KMA. Kindly advise on a 73-year-old type 2 on Treviamet, diamicron. Latest fasting is 4 to 7, RBS 6 to 8, HbA1c 6.4, 8.7, and yesterday HbA1c was 10.9. So that's probably a patient who you should look at in terms of, so if the HbA1c yesterday was 10.9 and this patient is on a sulfonylurea. Sulfonylurea really reduces sugar levels as compared to obviously the DPP-4 there and metformin as well. So if this patient is not getting controlled on that sulfonylurea, that's a patient you could probably escalate to insulin, or rather check the lifestyle and see if this patient is on a high load of sugar and might need change in therapy. So that's a patient you could probably escalate. Is the indication of HbA1c from the outset at greater than 10% from the outset at diagnosis or after the period of doing OHS? I think I've alluded to this answer in the sense that it could be at diagnosis, it could be not after OHAs. It could be in the middle somewhere, I don't know, but it depends on the patient. So if this patient HbA1 presents with HbA1c of 15%, has lost weight for over the past few months, and this is the first diagnosis of this patient, this is probably a patient who's insulinopenic and has had type 2 diabetes for quite some time and now has almost run out of insulin. You could initiate this patient on insulin. One more thing, you could initiate this patient on insulin, and eventually this patient could get off insulin as well. So sometimes I tell my patient, let's try and save the little beta cells that you have. Let's initiate insulin early so that the beta cells can take a rest and continue regenerating while there is this exogenous insulin that is taking care of the blood sugar. And as well, this patient is most likely very glucotoxic and very lipotoxic. So that, remember, that is what causes the free radicals to form, that glucotoxicity, and causes apoptosis. So this is a patient you'd probably want to give insulin from diagnosis, and at least to follow up this patient keenly, in the sense that you follow their postprandial glucose, fasting glucose, and you could probably eventually down titrate if they are tolerating the insulin quite well, and even probably eventually stop. For some patients, we do eventually stop. And please, let's not wait for all the OHAs to take effect and now the patient is not responding anymore. I think that is doing injustice to patient. You could initiate insulin and probably even take them off if they don't require, and that is, you tell the patient to watch out of symptoms of hypoglycemia. And symptoms of hypoglycemia, you don't have to wait for the neuroglycopenic symptoms of hypoglycemia. Even as little as telling the patient, if you're feeling more hungry than usual, that is an indicator that this patient's blood sugar is going low. So that is an indication of probably down titrating the insulin. So don't wait to give all the classes of oral hypoglycemic, oral glucose lowering agents, and then now you say, now you've exhausted everything, now you just go to insulin. No, you could initiate insulin early, and it helps in regeneration of the beta cells. So that is not essentially the case for all patients. So I think I would probably at this point emphasize on individualization of therapy, because it's not a one size fit all for all patients. And you need to look at various variables. And the other thing is, I think in our setup, we tend to have, especially I've noted a younger population who are presenting with a lot of insulinopenia, in the sense that you're finding ketones. And remember, there are other types of diabetes apart from type 1 and type 2, and this patient could probably be LADA. And we are diagnosing patients with type 1 diabetes even beyond 45 years of age or in their 40s. So again, always have that at the back of your mind, that this patient may not be type 2 diabetes, and this patient may be type 1. And these are the patients, and that's why we need to ask them to monitor their sugars, not just the fasting, but even the postprandials. You may start on basal, but you're noting, like the case that I presented last, that the postprandials are high. This is a patient who probably requires basal bolus therapy. So you may need to think of LADA, latent autoimmune diabetes, and also type 1 diabetes in terms of happening in not only in the young, but also in adults. So that's another thing that you should have at the back of your mind. So where did I reach? Okay. So would you kindly clarify on basal intensification when you have elevated prandial glucose, having the fact basal bolus is a long acting, and is there room for actrapid? Okay, so actrapid is a bolus, but it's the human. So actrapid can be used with the basal if the patient requires a bolus therapy. Like I told you, the fasting might be good, but the postprandials are high. So this is a patient who probably you need to intensify with a bolus therapy. And actrapid can be used as bolus as well. So I'm not sure I really answered your question, but you could ask if you could clarify. Can a patient who was on Mixed-AD be changed to basal? I think the anonymous was not following my presentation, because I think the second case was a patient on Mixed-AD, and we changed the patient to basal and oral, and the patient did quite well. Yes, you can. And I think also John mentioned in his presentation, there are some cases that you can change from that, the human mix insulin to basal, and they do quite well as well in terms of quality of life because of the glucose variability associated with that. Thanks for the presentation. Can basal insulin be used alone while eliminating the oglers that the patient was earlier on? So that I don't know if the question means, can the patient just use Lantus alone, or rather basal insulin alone without the oglers? They can use with the oglers, yes. But then again, you'd have to look at the patient's profile in terms of the sugars. So if you give one basal insulin in the evening, how is the fasting sugar? How is the 2 hours post-lunch sugar? How is the pre-meal sugar before dinner? How is the 2 hours after dinner? So that you can predetermine does this patient require other therapies? So because most of the times we combine the basal insulin with oral glucose lowering agents for the type 2 diabetes patients. So end-stage renal disease and basal bolus initiation per kg would still remain the same with risk of hypo. No, it does not remain the same because of the risk of hypo, as you have stated. So you may need to, depends with the patient again, because we have some patients who have end-stage renal disease and the sugars are really quite high, so they may or may not require. So this is again another case of individualization, but giving the basal bolus might not depending on the stage of, again, okay, it's end-stage renal disease, but you don't need the patient accumulating so much insulin, considering the fact that they're not eliminating like they should. Okay, what is the most recommended for blood sugar monitoring, FPG, postprandial, or RBS? You should, recommended is both fasting blood sugar levels and 2 hours postprandials, whichever prandial that you use, again, depending on the patient's therapy. Because again, remember again, this glucose testing strips can be quite costly for most of our patients. So for most patients, we tend to determine based on the therapy that they're on. Patients on oral alone, we could ask them to check once a day, depending on the control, if the control is not so bad. But even that once a day, we ask them to check different times. So if today they did fasting, tomorrow 2 hours post-breakfast, 2 hours post-lunch, 2 hours post-dinner, so that we get a picture of the whole day sugar. Because you find patients coming to the clinic with a nice diary written, fasting blood sugar, fasting blood sugar, fasting blood sugar. That's not fair. Patients should do their 2 hours postprandial. That's the only way you know that the coverage is good throughout the day. So we would recommend fasting blood glucose and postprandial. Again, recommended for patients on basal bolus is up to 6 times, because you do the pre-meal and post-meal sugars, at least so that you know you can titrate your bolus insulin as well based on the postprandial of that meal or pre-meal from the previous meal that they've had. So again, monitoring obviously best with continuous glucose monitoring, the CGMs, but very expensive for most of our patients, 99% of our patients. But that would be ideal for patients who could afford. Please put them on that, because it will give you a clear picture and of how the sugar readings are. Because for those patients, in fact, a lot of times, even the HbA1c, we tend to use the time in range for that patient. If it's above 70%, well and good. So the monitoring, I think, depends on patient and depends on a lot of factors for that matter. Isn't 10% of basal insulin a tiny dose to give as a as a bolus insulin dose? This is for the case of over-basalization. When you have your patient on basal insulin and you've been adding because this patient's HbA1c is not getting controlled, you keep adding the basal insulin to try and control the sugars. And so you find that the patient probably needs a bolus because the postprandials is what is keeping these sugars high. So what you do is that time you tend to get the 10% from the basal insulin, and you start that, and you don't stay at the 10%. Let me just put this out there. Insulin doses are never fixed. You titrate based on what the patient is eating, based on the patient's condition, so it's never a fixed dose. So if that 10% you see, for example, if the patient with 48 units of Lantus, 10% is about 4.5 units, 5 units, for example, you find is little based on the titration, based on the monitoring that the patient will do, you tend to up titrate. So it's never a fixed dose. Insulin is never a fixed dose. You find patients coming to you who, like my patient on Mixtard, she was on 28, 20 units for almost as long as she can remember. So that is not right. You should teach your patients to titrate based on the reading, because sometimes patients eat less, sometimes they eat more, sometimes they go for a party, sometimes they need to bolus more than they do. So I think it's really, again, patient-centric, again, empowering our patients to self-monitor and self-manage is quite important. I think that should be my take-home message. Kindly remind me what...
Yes, Dr. Let me just hold you on a bit. We have done up to 8:30. So, and I've seen the questions. It is unlikely that you'll manage to finish them. Maybe you can just take a minute, go through them and see what is very critical to answer. I saw the CEO of KMA in the meeting, and I believe probably she will want to say something so that we can wind up in time. Our attendance is very good, but I think we need to wind up because I can see there is a slight drop. Can you guys hold on a bit? Just in a few minutes, we shall close. So, Dr. maybe you can wind up with some few critical questions in your judgment. Then the rest we can see how can be answered. KMA have this data. Thank you.
Wow, that's 32 more questions left. I don't know how you would want me to...
Maybe you can pick one or two.
Oh, so
Like,
I
for
can...
example, I saw something that probably I will also wanted to hear, the reactive, somebody asked the reactive what? Let me comment on reactive hypoglycemia down there. Maybe you can answer that, Daktari. Comment, this is from Dr. G.P. Yosa, Mombasa. Comment on reactive hypoglycemia.
Okay, so basically, this reactive hypoglycemia is usually the postprandial hypoglycemia. It happens when somebody has had a meal and blood sugar drops quite fast. You expect blood sugar to not drop within a few hours. So it happens probably after a large meal of carbohydrates. The patient has taken carbohydrates and the patient produces too much insulin, and the drop in, I don't know, can you hear me?
Yes, I can hear you, Daktari. I can hear you. You are very loud and clear.
So the drop happens quite fast, probably within a few hours, because of the large meal. The pancreas is stimulated to produce the insulin. Yeah, a large increase in insulin is high, so the patients tend to drop the sugars quite fast. And because again, carbohydrates tend to peak quite fast, the sugars quite high. If you look at especially the simple sugars, the simple carbohydrates. So when they pick it quite high and the patient responds by producing quite a steep amount, an increased amount of insulin, the sugar tends to drop quite fast within a few hours. I think within 3 or 5 hours or so, the sugars drop. So that's reactive hypoglycemia. So the patient gets the symptoms of hypoglycemia usually, yeah?
And maybe the last one, Daktari, is for patients in the ward who are on rapid insulin, how do we transition from the rapid insulin to Lantus? I think we can take that one and we will answer the others on mail.
So that again depends on the patient, the different patients. The Lantus, the total daily dose of the insulin that the patient is taking is what you need to calculate, again, vis-a-vis the patient's weight, and then you give that for the Lantus as once a day, because you'll have to get the total daily dose of the total daily insulin dose that the patient has got, so that you can determine that. Yeah.
Okay. Thank you. I think we will have to stop somewhere. We've done 5 minutes past our 8:30. And please, we are sorry. The questions are so many. I believe Daktari would have loved to take most of them, but we can't beat the time. I want to commend every participant who have joined us. I think we've had a wonderful session. We were close to 250. And I can see we are still almost up to 180 people are still on. So this means that the sessions have been very educative. I've seen guys from Kapenguria. I've seen very familiar names, some serious names in Nairobi. I've seen from Mombasa. I've seen people from Kisumu and from all over this country. And I think KMA has enabled us to reach nearly every corner of this country. Somebody asked a question on where you can get Lantus. Lantus is well available in most of the county hospitals. And it's supplied from KEMSA and from MEDS. But you can reach us in case you have challenges to reach us. We have Lantus vial. There is the Lantus pen. What is available in the public hospital is Lantus vial mostly, but you can always, the Lantus vial price is standardized, whether you buy it from a public sector, from a chemist, or from whichever place you are, the price is standardized, but the solo star must be varied. So wherever you are, if you have a challenge getting Lantus, please reach us. We are very much available and almost in every part of this country. Before I close, I don't know whether we still have, let me just check whether we still have the CEO of KMA. I think she could have dropped. Peter, can you confirm that?
I think the CEO should have dropped from another meeting. So on behalf of Kenya Medical Association, I would like to thank all the participants today for attending the meeting, and to our speakers and to our sponsor, we really appreciate it. Thank you very much.
Okay, thank you, Peter. And I also saw my colleague Dina. You want to say something to the participants?
Thank you everyone for joining us. It's always a pleasure to partner with you, and have a good night to everyone.
And thank you, everybody. Thank you, Daktari, for your wonderful presentation. Thank you, John. And please keep joining KMA webinar. I can see the reach is very wide, and we'll be back here and in several other associations that we partner with to disseminate this important information. You have a very restful night. Bye.
Thank you. Bye.